strikes someone in the U.S. every 40 seconds. And in fact, it's the leading cause of disability in our country. And here at Enloe Medical Center, we see someone experiencing a stroke every single day. That's the topic of today's Facebook Live. I am Deanna Squires, Enloe's Community Outreach Coordinator, and I'm joined today by Dr. Navin Varma. He is a neurologist and the Medical Director of Enloe's Stroke Program, and Sean Abrams, one of the paramedics with Butte County EMS. So thank you, gentlemen, for joining us today.
Welcome. Thanks for having us. Thanks for having us.
Our pleasure. So May is Stroke Awareness Month, and we want to remind you that if you or someone you love is experiencing a stroke, or if you think they might be, the best advice we can give is to be fast and call 911 right away. If you have questions about your health or that of a loved one, we do want to encourage you to talk to your healthcare provider. We're going to be talking about a lot of information today, and it's meant to be educational, not to be specific medical advice. As we go through today's program, we do want to encourage you, as always, to post your comments and questions in the comments field. We're going to be watching for those, and we'll try to answer as many as we can during our time together. And with that, how about we get started?
Sounds good.
All right, so Dr. Varma, what exactly is a stroke?
Good morning. Thanks for having us. Thanks for paying attention to us and learning. This is really important for the community. There are three different kinds of stroke. The most common kind is what we call a thrombotic or thromboembolic, usually thrombotic. A stroke is a loss of blood supply or brain injury because of a blood vessel problem. The most common kind is where an artery over time has shrunk down and then it seals. And it'll seal because of clotting mechanisms of platelets, and as the blood vessel ages, it just becomes more prone to doing that. As it clots, everything beyond that artery is now deprived of oxygen and glucose. And as the brain cells lose oxygen, they die off. So that would be the thrombotic kind of stroke. And embolic stroke is that, again, your blood vessels kind of are shrinking down over time, but then a fleck, a clot will break off either from an artery in the neck or the heart, and it will actually go into the brain, into an artery, and plug that artery up. And again, everything downstream from that artery will lose its blood supply, lose its oxygen, and start dying off. The less common kind of stroke, but still important, is what we call a hemorrhagic stroke. And in that situation, what's happening is that the blood vessel ruptures. And usually what's happening is, over time, as your blood pressure strikes the wall of the blood vessel, it becomes injured, and then it kind of opens up a little bit. We call it a little aneurysm around there. It's not the scary kind of aneurysm, but it's still scary. And then eventually the blood pressure is just enough to break the artery wall, and then the blood actually tears into the brain at pressure. So that would be the hemorrhagic stroke.
And most people think stroke is really something older adults experience, right? But it can affect people of all ages, right?
Yeah, in my experience, I've had patients with strokes truly of all ages, from the prematures to the elderly. Mm-hmm. The majority of the strokes do occur in people over the ages of 60 and 70, but a substantial number, 25%, will occur in younger adults as well. There are risk factors at a young age: high blood pressure, diabetes, cholesterol, these kind of same issues that affect everybody. Smoking, meth use, cocaine, these kind of all factors kind of build in and increase the risk of stroke at a younger age. So it does affect all age groups, but the majority occur in the elderly.
Mm-hmm. So you mentioned a few of the risk factors, like smoking, drug use. What are some of the other risk factors? Who is at higher risk typically?
So the most common risk factors: high blood pressure, diabetes, high cholesterol, smoking, excessive alcohol, drug use, estrogen use in women seems to be particularly increased risk. Of the drugs, meth and cocaine are the two big ones that we worry about. And then you have inherited risk, just your genetic risk for vascular disease. If you've had a heart attack, that increases your risk. If you have a certain kind of heart rhythm called atrial fibrillation, that increases your risk. And if you have clotting or atherosclerosis in the arteries of your neck, that increases your risk for stroke.
So a lot of things that maybe we don't have control over, but also a lot that we do.
Yeah, quite a bit actually that we have control over. And a lot of that control really starts earlier in age with good, healthy lifestyles, with a proper diet and those kind of behavioral approaches that we talk about as far as prevention for stroke.
Right, the exercise, keeping a moderate weight, all those things we talk about every single month that now they apply to stroke too.
Yeah, and I think at this point people kind of have heard it. It's just a matter of implementing it.
Right, and giving them more and more reasons why it's so important to make those healthy behavioral choices.
Right.
Yeah. So Sean, be fast. We've heard that term. When you start out with it, that's our best advice, is to be fast if you think someone's experiencing a stroke. But how can that help people? What is that acronym, and how can it help someone recognize if that's what's going on?
Well, be fast is a great tool for the general public to use. In fact, I mean, we use it in our assessment as well. Parts of it, we look out for the signs of stroke, but it's a great tool to use. Be fast, every letter in the Be Fast acronym stands for an actual sign of stroke, with the exception of T, the last letter, which I can get to a little bit. But B stands for balance. If you have a sudden loss of, or sudden onset of loss of balance or coordination, definitely something to be concerned about. If you're walking fine 1 minute and all of a sudden, the next minute you're staggering side to side, or you don't think you can keep your stance and you feel like you need to sit down, definitely something that needs to be evaluated. E stands for eyes. A sudden loss of vision in one eye or both, or a sudden onset of blurred or double vision, definitely something to be concerned about. That's a sign of stroke. F stands for face. A sudden onset of facial drooping or numbness to one side or both. I suppose the numbness could come on, but a lot of this stuff we're talking about is unilateral, meaning one side of the body. If you're having a hard time telling if someone has, some facial drooping, you can ask them to smile. If they have an uneven smile or asymmetrical smile, that's definitely a sign of stroke, something that needs to be evaluated. A stands for arms. So a sudden onset of numbness or weakness on one side of the body. That can include an arm or a leg, or both, an arm and a leg at the same time. So, there are definitely severities to this. There's mild, moderate, severe. It can be completely flaccid to one side. You can't move an extremity at all, or maybe just a little bit of weakness where it wasn't there a minute ago, and you notice you picked up a glass and you're not as strong on that side. Something to be aware of. It's a sign you need to call 911.
And you mentioned you can have somebody hold
Yeah,
their hands
if you're having a
out
hard
to-
time telling if a loved one or your friend is having that weakness, have them stick their arms out in front of their body. Generally palms up to the sky, have them close their eyes, and if you see an arm on one side drifting back down, that's a sign that they have weakness on that side. So we call that drift. So yes, definitely call 911 because that is a sign of stroke. So S, yeah, S stands for speech. I think this is probably one of the easier signs to pick up on. I think because it's an audible cue. You hear people talking to you, and all of a sudden their tone changes. Their sudden onset of slurred or garbled speech. If you notice they're having a hard time forming a sentence, whereas they were talking to you, perfectly just before. Now they can't even get out something simple as I need to get up and go to the bathroom, or whatever the thought that they're trying to convey to you. If you have any suspicions, you can ask them to repeat a simple sentence for you. The grass is green, the sky is blue, whatever comes to your mind. If they cannot repeat that sentence for you, definitely have them evaluated. That is a sign of stroke. So, and then T, as we mentioned, the only letter in the acronym that doesn't stand for a sign, but probably the most important letter in the acronym, and that's time to call 911. Because if you're exhibiting any one of these signs, one or more of these signs, this is a medical emergency. Don't hang out, wait to see if this is going to resolve, see if your family member is going to get better, or yourself. You're only doing more damage. So if you notice or exhibit any one or more of these signs, call 911. So,
Thank you.
yeah.
So the message of being fast, don't hesitate. So I've heard the phrase, time is brain. So Dr. Varma, can you expand a little bit more on that, why it's so important to respond quickly?
So the brain is very sensitive. It does not tolerate a lack of oxygen for a very long time. You can lose oxygen to your arm or your leg for much longer, and the tissue will recover.
It gets tingly.
It gets tingly. It'll actually turn blue, but you can still recover it. But if your brain is so sensitive, it's so important to who we are, even a little bit of loss adds to disability. And that's, stroke is the leading cause of disability, and that's really what we're trying to prevent with these treatments here and things. So you can imagine, as you lose more brain cells, you're getting more disabled. Now, there are different numbers that people put out that talk about you're losing so many neurons per second or per minute or something. Because this actually depends on the size of the artery that's hit. So if the artery is a large artery, then you may actually be risking a third of your brain, which is pretty important.
Yeah.
But you can also lose a very small part of the brain. And it sounds like, oh, big brain, little brain. But actually the little spots, if it's strategic, can hit you in the right spot, and now you're paralyzed completely. So time is important. There are treatments that have to be done very quickly. The quicker they're done, it's been shown that they're more beneficial as far as reducing long-term disability for patients with stroke. And so the more you think about it, the more delays that happen, the longer it takes to come in and be evaluated, the more brain injury is accruing over time. And that's, you don't really want to be hurting your brain over and over again.
Right, because it's not reparable, like you mentioned.
Correct.
Right. So we have had a couple of questions or comments posted. So maybe now's a good time to address that. So somebody asked about hormone therapy. You referenced birth control increases a woman's risk of stroke potentially. So for women who are maybe in menopause, I assume this is referring to, how does that affect their risk?
So every individual is different. There are benefits to hormone therapy and there are side effects to hormone therapy. We do know that pregnancy itself increases the risk for strokes, and there's different kinds of strokes that happen during pregnancy. We believe that's largely hormonal. Women who have a history of migraines, particularly complicated migraines, will have a risk for increase of stroke when they're taking estrogens, like birth control pills. Both estrogen and testosterone have been shown to increase the risk for stroke to some extent. But again, if you're looking at the disability, you're using the medications, hormone replacement, to improve something in your life, to improve your ability. And a side effect of that may be a stroke with disability. So you're balancing off that pros and cons of taking hormone replacement therapy. It's a very subtle discussion, individualized discussion, probably doesn't deserve an across-the-board recommendation at this point, but it does need to be consideration in taking that treatment.
Something to talk to your physician about when you're considering that kind of treatment.
Absolutely.
Yeah, that was one thing that when we talked earlier this week, before today, then you really reinforced with our team the quality of life component with stroke. And that's why we want to be fast. That's why you don't want to second guess and wonder and think it'll go away. So some of these treatments, maybe that kind of plays into that. You're looking at quality of life and balancing the risks.
Yeah. And stroke is, it's a disabling illness. It does have its lethal effects. People do die from stroke. But stroke in particular is so common. So many people in their lifetime will have a stroke. It really brings out this issue of why we're alive. We know we're going to die. We know at some point we're going to have a stroke or a cancer or a heart attack. Something's going to take us and take us out of this world. But in the meantime, how are we balancing the risks of life and the benefits of different things that we do during life? Those are incredibly important decisions. It really is fundamental to life as a human being. This is why I love neurology. This is kind of important.
Right. It's how do we live our best life possible and with all the tools and resources we have. Yeah. And the other question was about nutrition. So with red meats, does that play a part from a nutritional standpoint? Does that in any way increase stroke risk?
So stroke risk, think of it as vascular risk. Your whole blood vessel system is responding to who you are as a behavioral person. Genetics, of course. So anything that increases your risk for atherosclerosis, for heart attack, is going to be parallel with stroke. So the general recommendations has been that we want to have more fish and less red meat. That we want to have more vegetables than protein or meat itself. That we want to have less calories in general. The best dietary science that I've seen has been related to quantity. That it seems respond to the specific pieces of a diet differently, but bottom line is quantity. If you reduce your calories, for Americans that could be a general recommendation, reducing calories. And people with 1,500 calories a day tend to be healthier as opposed to the average diet of 2,000 calories a day. So yes, the kind of food you eat matters. Yes, there's all sorts of stuff in foods that we are worried about, but the bottom line is to reduce calories and to be increasing exercise.
I think everything in moderation is what he's trying to say, right? So that just goes with a lot of things that we do, you know. Try to stay healthy, exercise, but you know, if you want to have a hamburger or steak, you know, every once in a while, that's fine.
That's your quality of life.
Exactly.
You enjoy that.
Right, that's the quality of life.
Yeah.
Right. Everything in moderation, but like you said, you know, things are going to come along with those choices that you make. So.
And another good word is intention. I think when you're living your life, the more intentional you are with it, you can say, okay, why am I enjoying this hamburger? I hate cows, that's why I enjoy hamburger. Or, boy, this really tastes good and I am enjoying it.
Right.
And I'm walking down the street. If I'm skateboarding down the street and I have a chance of getting hit by a car, I better be balancing those things out. The more intentional we are with life, I think, the more we can choose, in this thing I want to be in moderation, in this thing I don't.
So, thank you. All good advice. So we said how important time is. So when somebody calls 911, Sean, I'll ask you this, what should they expect?
Well, definitely an immediate response. So when we are dispatched for any call, you know, whether it's lights and sirens and the fire department's coming with us, or it's no lights and sirens and a silent approach, we're leaving immediately. When we get dispatched, we're getting in our ambulance and we're headed your way. So you can expect an immediate response for that. When we get to the house, depending on the personnel that we have on scene, you can expect a lot of things being done, a lot of questions being asked, because we do want the history of kind of what's going on, the history of the person in question as well, medical history, medications, what they're currently taking, specifically to blood thinners, any kind of anticoagulation therapy they're on, Plavix, Coumadin, aspirin, as simple as aspirin. If you're taking a baby aspirin a day, we want to know about it. And then any allergies to medications. Personnel at scene are going to be taking vital signs of the person in question. So you can expect, you know, heart rate, a blood pressure, SpO2, which measures your oxygen saturation in your blood, blood glucose, SC, we want to check your sugar. These are things we want to check immediately, so if there's anything that we can correct immediately, we're going to go ahead and do that. Once we get all the information that we have, possibly we'll be doing more in the house or wherever we happen to be called out to, or we're going to get the patient on the gurney and get him in the ambulance, and the work continues. We're going to get you on electrocardiogram, we're going to take a really good picture of your heart, we're going to get an IV established. We want that access, so when we get to the hospital, the stroke team has something to work with when they want to give their medications as well. A blood draw, we're going to draw some blood in the field so we can get that lab work started as well. Any kind of airway management, we're going to address that as well. So a lot of stuff going on. You're going to see it in a prompt and timely manner, because we know the importance. If we suspect a stroke, you might see it kick up into another gear, because we know how important it is to get this person to the hospital for evaluation as well as treatment.
And is there anything the people that are with the patient can do to help you when you arrive on scene?
Yeah, absolutely. I mean, if you're a family member or a loved one that has access to any kind of medication list, or if you're just a witness of this, one of the most important things, besides anything else I mentioned before, is the time of onset. When this started is probably the most valuable piece of information that I can pass on to my stroke team. If you didn't witness this, anytime, if you or anyone else, we want to know the last time this person was known well. So if you didn't actually witness the onset of these, but I was here last night, you know, at 9 o'clock, we had dinner together, he was fine, I showed up this morning for breakfast, not so much. So that's important to us, because there is a window for treatment here, so we do need that last known well or time of onset. If you are witness to it, even better. So if you can make note of the time, that is probably the single most important piece of information that I can pass on. So.
Because that does affect treatment options
Absolutely.
Down the line.
You bet.
So then, Dr. Varma, once that the crew gets the patient to the hospital, what happens at that point?
I'd like to make one more point on piggybacking on Sean. There's been science that shows that if a person is brought in by an ambulance, treatment is faster and more efficient than if the person is brought in by a private vehicle. So actually contacting EMS helps in many ways. One is it gives you the support as you're trying to drive to the hospital. You don't want to be worried about the person next to you breathing or not. You want ambulance people doing that kind of thing. And what Sean and his crew are doing is getting the patient ready for treatment and evaluation, which you can't do in your own private vehicle. So we're expediting the care, and again, we talked about time is really, really important here. So I think contacting EMS, if you're worried about a stroke, is in itself a very important thing.
That's good advice.
Once you get into the hospital, here at Enloe and really nationwide, other hospitals, hospital systems have established what are called stroke centers. We're at a primary stroke center, and there's comprehensive, and then there's receiving centers, so there's different levels of stroke care that you can get. Again, time is the key feature here. So as you come in, this whole team attacks you. And,
in a very good way.
In a very good way. This is your army. You want them attacking you. And we have EMS bringing patients in and actually working with us through the process of the initiation of care. We have triage and nursing who begins to assess patients very quickly. Usually even before the patient has arrived, the neurologist and the emergency room doctor has been alerted that this is a patient coming in with a possible stroke. So we're getting in there, we're getting the patient out to getting a CAT scan, a brain scan, as quickly as possible. We're going to start blood work as soon as we have it, either from EMS or we're going to be drawing our own. We're going to be getting x-rays, assessments, and we're going to need to talk to the family patient as soon as possible. Very often in the CAT scanner, we're all there, the whole team, with the patient. As the patient is being moved in for the scan, we're still in there talking to the patient, trying to get this going. Through that evaluation, we go through kind of three parts of it. One is the history, which is talking to the family and saying, what was the last seen normal? When did these problems begin? And it's that sudden loss, that BFAST thing, and how bad is it? How was the patient before? What are the medications? What are the potential risks and complications to the stroke process? And then we're examining the patient, we're assessing how severe the stroke is, and then finally we have to make that decision on what treatments are available. So if it's a hemorrhagic stroke, the bleeding kind of stroke, again, this is a blood vessel that's torn. There's not much we can do to fix the blood vessel. But if you imagine there's a torn blood vessel and there's blood pressure pushing blood into the brain substance, if we can lower that blood pressure, at least it's not pushing as hard. So a very rapid control of blood pressure becomes a priority.
And that would just minimize that influence on the brain, that long-term disability you talked about.
Right, and again, brain is like jello, and this is blood pressure. This is pushing through the jello. We say dissecting or tearing brain. And so if you can reduce the force by which you're doing that, what will happen is that the clot itself, the blood that's leaked into the brain, will start sealing the blood vessel. But if you have healthy brain here and you've got clot here and you still got pressure pushing into the clot, then you're going to tear more and more blood and therefore cause more disability over time. So very rapid control of blood pressure becomes important. If you have a thrombotic or embolic stroke, that's where the artery is actually plugged up. There's a medication which can go in and break up the clot and get the blood flowing through the artery again. That medication itself has its own risk, and so you kind of have to balance off this whole issue. So we're assessing this. Now, before we get into that medication, one of the other things we like to think about is what are called stroke mimics. So patients will have what sound like strokes, but they're not really strokes in that sense of a blood vessel that's been injured. Patients after a seizure will often have a sudden paralysis. They'll wake up with a paralysis from the seizure, and their arm or their face won't work right. They'll have problems with their balance, and their speech will be slurred. So we don't want to be treating something that will naturally improve, like a seizure. Migraines can be stroke mimics. So people can have a migraine syndrome where they're, again, paralyzed, they have facial weakness, they have a drift and things, and then over a short period of time that will improve. People with migraines lose vision, and then over time that will improve. Stress is one of the most interesting things to me that comes in as a stroke mimic, where someone, as a response to stress, they'll actually be paralyzed. on one side or the other or both, and we again want to treat that appropriately. We don't want to be using medications for something that doesn't need medications.
So does the CAT scan you mentioned, is that how you would verify if it is a stroke or if it is one of these mimic conditions?
No, that actually comes back to that history, listening to the patient, and the examination. The CAT scan helps us to identify if there's a hemorrhagic stroke. The hemorrhagic stroke is then bleeding into the brain. The other stroke is a plug. So we want to open up that plug. Now, if you're bleeding into the brain, we don't want to open up any plugs.
Right, you want to keep that
you
back.
Want to keep that plugged in. And so the medication we use, TPA, will actually open up the plug.
Okay.
So in the scenario that we're worried about, we're going to say, oh, we don't see bleeding in the brain. This is not a stroke mimic. Now we've got a stroke that's causing significant disability. Let's start treating this.
And that's the TPA,
That's
the
the
medication.
TPA,
Okay.
right.
So TIA, so the mini strokes, that's another condition that we haven't talked about yet, but how does that play into all this diagnostic and treatment discussion?
The TIA, transient ischemic attack, or a mini stroke, is a challenge. It's one of those things you can identify after it's over. Okay, so if you had an episode of numbness and then it goes away and it comes from the brain, so you can get numbness because you hurt your arm.
Right, you hit your funny bone.
Right, that's right. Not a stroke.
Right.
But
goodness.
you have numbness that hits your arm and it's coming from the brain, and then it goes away in 5 minutes, we call it a TIA. If it goes away in 24 hours, some people will call it a TIA. If it goes away in 72 hours, some people will call it a TIA.
But you don't want to wait that long, so that's kind of a
Right.
hard dilemma for
So
people.
after it's over, you look back and say, oh, that was a TIA. But in the meantime, if you're sitting there waiting, hey, is this a TIA or a stroke, and the person is paralyzed, exactly as you
911.
said, you don't really want to be checking this out and waiting to see what happens. You need to act when you have the time to act.
Right.
So TIAs are warnings that you're going to have a future stroke. They're important. Take them seriously. The more the disability, take them seriously. But that's why you're coming to the hospital. That's why you're not treating this on your own. You need the experts to really assess this and say, hey, we've seen this before, this looks this way, we need to be doing this now. And really working with you as the family and the patient to decide what the next best step is. The medication TPA, for example, has a risk to it. It has about 1 in 5 people will actually bleed into the brain because of the medication. Again, you've got a plug, you're opening up the plug, and that'll cause bleeding into the brain. Most often that's not a severe bleed, but it can be. And then the other risk is that of the people who get the medication, about 1 in 20 will die. Now, that sounds like a huge risk. It is a huge risk, but people would die from strokes even if you don't intervene. So there's a balancing factor in all this.
And it goes back to that quality of
Quality of
life,
living.
right?
Yeah, and making that judgment and the
Right.
intentionality of the moment. You say, hey, this medication could harm me. This is how much disability we have. The patients who get this medication, in general, have a 38% improvement in disability over time. So you've got some improvement, substantial, 38 is pretty good, versus some risk of the medication harming you. And so you've got to make that choice and say, is this the right thing to do at this moment? Which gets back to this person, this individual, in this setting, family, patient, doctors, nurses, all of us saying, what's the right thing to do here? It really takes that expert judgment. It really takes this team, which has put all the resources together at the one time for this one patient at this one moment to make that right decision.
So that's one thing when you're talking about those really hard conversations and hard questions going on at a very high stress time. So advanced healthcare directives, we haven't talked about that yet, but that's something I think we've talked about in other programs and advise people have those conversations with your family now when you're healthy, there's not a crisis, so that when there is a crisis, you know what is the wish, right? How does that play into these questions you're sharing today?
It's incredible. It's having this discussion with a patient having a stroke is challenging for the individual, the patient.
Right.
We of course want to do what's right as that patient defines it. We don't have recipes here. We're trying to say, hey, what's your life about? What are you doing with this? Are you looking to fight everything possible that comes towards you? Or are you saying, you know, I've lived my life and I've done a good job, or not, and I'm ready to move on? Are you, as this individual who's coming to us now, what are your intentions? How can we help you to live your quality of life? We have this medication that can reduce disability, but it can cause you harm. We have these interventions, intubations, etc., that are life support, but you may be left with a significant disability. Is this the kind of life that you would choose? Now, no one knows the future. One of my favorite sayings goes from Yogi Berra, the future ain't what it used to be. But you have to act in the moment. You have to make a decision now of what your life is about. And I think the goal of medicine really is about empowering the individual to make that decision now. And that wisdom, 2 years old don't have it. But as you get older, you should be looking at your life and saying, this is the spectrum of my life. This is what I want to have done. This is what being me defines me. Right. And therefore having a plan of saying, if I have this kind of condition, I'm ready to pass on. If I have this kind of condition, I'm ready to fight this thing as much as hard as I can. Of course, as you think through these strategies, probably, certainly, there are people around you who are affected by it. So you need to be talking to those family members, friends, and saying, hey, this is what I think my life is about. And usually you have friends and family that you do talk about, hey, this is what life is about. And so taking that extension and saying, if something were to happen to me, this is how I would think about it. I don't think it's a natural conversation. I think human beings kind of enjoy talking about themselves. And they talk about what their life is about. And as they talk about it, part of life is dying. And therefore having advanced directives, having the ability to talk to people, is a really important aspect of things.
Well, and having that conversation when it isn't so heavy because there is a crisis makes it, I think, maybe a little bit easier.
Less stressful.
Yeah.
Absolutely.
Yeah. That's one less thing. I mean, I've had many patients and family members in tears as we've gone through this discussion. It's a frightening situation. It's potential disability, potential nursing home placement, loss of autonomy, loss of who you are as a person. It's a very frightening situation. And trying to help people through that, that's what we do. But if people have thought it through, again, we want to do what that patient feels is the right thing to do.
Respect their wishes.
Absolutely.
Yeah. So, quick question, are strokes hereditary, or is it just anybody, anytime?
Quick question, hard answer.
Of course it is.
The risk factors are hereditary.
I tried to sneak that one in there.
Yeah, right. So certainly genetics plays a role. We're all going to die. We're all going to have a stroke, a heart attack, a cancer, a bus hit, something like that. So being alive has a hereditary risk of dying. So,
like 100% risk.
Like 100% risk.
We're trying to extend that
out. Has not been solved yet. So it really is more, what can I do? So yes, we can blame our parents for all sorts of things, and people do. But as an adult, you blame yourself. And you say, okay, what can I be doing for my life? And that takes us back to these kinds of preventative things. Again, the stuff that you hear about on every media source there is. Exercise properly, control your diet, don't smoke, alcohol in moderation.
Drugs are bad.
Don't do drugs.
Don't do drugs are bad.
Just say no.
Yeah, don't get your head hit. These are kind of important things, and we've heard these, but again, it's a matter of implementation. And that takes us back to that moderation and intentionality duality there. We need to be intentional in our life so we can have a life that we choose.
So maybe we should talk a little bit about after a stroke. What is the recovery process, and what are the resources for patients here at Enloe?
So at Enloe, we have a tremendous stroke coordinator.
Yes, we do.
Sean Abrams. She's a contact person who refuses to come on camera.
That's why we have her husband with us.
Right. And she is available by email, by telephone, by our webpage and things. She very well understands what we have at Enloe and how to get into that individual. But we have EMS that's coordinated. We have nurses, we have lab techs, we have nurses that are specifically trained in stroke, we have the neurotrauma intensive care unit, we have neurologists available every day 24/7. We have rehab doctors who come in and help to coordinate the recovery from the stroke of physical therapy, occupational therapy, speech therapy.
Both inpatient and outpatient.
Inpatient and outpatient. Well, an inpatient at Enloe, then an inpatient at Enloe Rehab. So the full spectrum of time that the patient will go through. We have hospitalists who are internal medicine doctors who are an excellent support to the stroke program and help us manage the complexities of stroke care. So we have quite a thorough team. We have a case management that helps us to kind of strategize about patients. We have palliative care that can help patients think through the more complex issues about what life is around the stroke and how it's changed now.
And really support that quality of life we were talking about a few minutes ago.
Yeah,
Absolutely.
And then we have outreach programs like this.
Education, very important.
Education, that's right. And again, getting the population, our local population, aware of stroke, recognizing stroke so they can call EMS and get in here so we can have the options of treatment. Hugely important resources. And then I think really the bottom line is Holly. She's an incredible coordinator, well respected by the team because she actually does care. In the old days of stroke treatment, we used to talk about champions. That if a hospital had a champion, someone who actually was passionate about the treatment of stroke, you would get better care. And I think at Enloe, the resources are that we have multiple champions. We have champions in the EMS field. We have champions in the emergency room. We have champions amongst the neurologists, in the hospitalist group, in the nurses and on the floors. And then we have Holly to coordinate all that. We really have a team of champions here.
Right, we're very lucky in that regard. So if somebody does want to reach out to Holly, then you can always go to our website at www.enloe.org. We do have a section dedicated to stroke, and there is a way to reach out to her directly, so feel free to do that. There's also other resources we've talked about. We're going to put in the comments just for more education, including the American Heart Association, Stroke Association. The Get With The Guidelines is something that we are certified here at Enloe, and there's information online. We'll make sure that you have access to that link. So there's so many facets to it, but it all comes back, I think, to how we started, that it's really up to you at home to know the signs. I think, Sean, you mentioned there's a statistic that only 38% of people know the signs.
Yeah, absolutely. Very disturbing.
It's very scary.
Yeah, 38% of people were, only 38% of people were able to recognize a stroke symptom and call 911, which leads to 62% of not. And consequently, here we are with stroke being the leading cause of long-term disability and the 5th leading cause of death in the United States. So that's why we're here today, right? To get this education out. So hopefully we can build on that number. 38% is far too low. It needs to be much higher.
Yeah, we want it to be 100%.
Absolutely.
So should we remind them? Balance.
Balance. Eyes, face, arms, speech, and then time to call 911 if you're exhibiting any one or more of these signs.
All right, anything else before we conclude today? Any last words of wisdom or things we want to make sure our community knows?
I think people, not patients, people need to be aware that they can do things.
Yes.
That really has to be the emphasis of this. Before they have a stroke, they can be doing the exercise, the diet, and not smoking, things that we mentioned before. Once you've had a stroke, medications we use to prevent a stroke aren't great, but they're pretty good. They help. So if your doctor is telling you take an aspirin, take a Plavix, take a warfarin, or take one of the newer anticoagulant medications. If you have atrial fibrillation, if you have clots in your neck that need to be surgically removed, these have been shown to be beneficial to reduce the risk for stroke. And to some extent, it's letting us do things to you, like tell you to take your pills. But to a large extent, and almost to an equally powerful extent, what you do after a stroke is hugely important. And strokes themselves can cause depression. Working through that process in the recovery process and saying, hey, this is important to me. I need to be putting in this. I think putting the power into the individual's hands. This is your life. This is your intention. You don't need to be. You can choose to be involved in how your healthcare is,
Right.
and this is your responsibility. I think we forget that in medicine a lot.
Yeah, it's a very powerful reminder. Thank you. I think one thing just occurred to me that I don't think we mentioned, so sorry if we did, but it's worth reminding. We've talked a lot about time, and with the TPA drug, that's really part of why time is so important, right? Should we mention just a little bit about that?
Yeah, there are different time windows technically. Again, the sooner you do it, the better.
Yep.
So if TPA is an option, basically if there's a clot in an artery, then this medication TPA will go and open up the clot. We want to deliver it as soon as possible. The medication's risk goes up after 3 hours. The risk goes up even higher after 4.5 hours. So if we aren't in that time window from the last seen normal, that time when you tell the EMS this is when this started, or this is the last time I saw this person normal, 3 hours, 4.5, but those are kind of hard stops. Again, from us, that's a science basis. This is what the evidence supports. We know that the risk increase. The sooner, the better. There are other treatments for strokes beyond that, but they require specialized kind of interventions, which are less proven, but as time has gone on, have become more and more proven. So you could allow yourself to wait 24 hours? No.
Don't do it.
Don't do it. The sooner the better, and treatments are known to work better, as in reduced disability over your lifetime, sooner than later.
Or no disability whatsoever.
Yeah.
Right.
I mean, the sooner you get in. We had a guy recently that we brought in, and he had a large vessel stroke. He even mentioned that he thought about not calling 911. He wanted to wait it out, but he was flaccid on one side, completely lost movement on one side of his body, and was actually thinking about waiting to see if it was gonna pass. He didn't. He made the right choice. He actually called 911, and this is minutes after the onset of the symptoms. Got him in. He was assessed. Dr. Varma did what he did. The team did what they did, and TPA was administered. He walked out of the hospital with 0 deficits, 0, and it was a large vessel stroke. So, I mean, it's not always going to be a disability. You're not always going to have some minor deficits. You may, but there is a possibility that you get this soon enough, you're going to be walking out of the hospital with the same quality of life that you had when you went in. So, and that's our goal.
That's the goal.
Absolutely.
I think that's the goal, but the reality, it's great when that happens.
Bad things
It's great when
can
that
happen.
Of course.
and
But we want to
again,
increase our odds that would be our
Yeah,
outcome.
right.
Share that story just for example. You
Yes.
know, there is a possibility that, not everyone who suffers a stroke is going to have a long-term disability.
Correct.
The odds say yes, you are probably going to have some sort of disability or deficit, but hey, I mean,
and you
just call.
Yeah.
And
Call
in
911.
the long term, I think, again, from that personal responsibility, you as a patient, as a provider, want to say, I did the right thing at that time. I had the opportunity to do the right thing, and I did the right thing, the best decision we could make. And then whatever life brings to me from that, I know I've done the best I can.
Absolutely.
That empowerment you talked about.
You bet.
All right. Well, thank you both very much for being here, sharing all this great information. Thank you, everyone, for joining us at home. Remember to be fast. Don't wait. We are here to take care of you in those moments of crisis, but do what you can to live the best quality of life that you can. Thank you so much, and have a great day.
Take care.
Thank you.